I'm here to talk about Motivating Youth Recovery, or the MIR program, and it's located at 26 Queen Street in the middle of Worcester, basically. It's one of two stabilization and detoxification units that exist for kids in the state of Massachusetts. So MIR is a statewide program. We serve kids throughout the state of Massachusetts, mostly Central Mass, Western Mass, and Northeastern Mass. It's a high-intensity level of inpatient care for kids. 24-bed inpatient unit. We serve kids that are between the ages of 13 and 17. We can also admit 18-year-olds on a case-by-case basis. And 18-year-olds would be admitted if they are still in school, if they're involved in child-serving state agencies, or if an adolescent or an approach to treatment is more developmentally appropriate for the 18-year-old than an adult version of treatment. Kids don't need detoxification to be referred to MIR. As you heard earlier, detoxification services or medication-assisted detox really is used for kids that are abusing opiates or kids that have extensively abused alcohol and or benzos and are experiencing withdrawal. So not all kids really have to require medication-assisted detox to be referred to MIR. Actually, only about 25% of our kids at any given time are on a protocol where they receive medication for withdrawal. We use two scales to really determine whether kids need medication to manage withdrawal symptoms. That's the COWS, which is an opiate withdrawal scale, or the CWA, which is a scale that is screening for withdrawal symptoms for alcohol and benzos. Just wanted to talk a little bit about a screening tool that you might all be familiar with or you might not be familiar with, but this was mentioned earlier. And this is a very quick and easy screening tool that you might be able to use with kids that you're working with in your settings. It's called the CRAFT. Very quick and easy to use. You really start off by asking these three questions. In the past 12 months, have you drank any alcohol more than a few sips, smoked any marijuana or hashish, or used anything else to get high? If you get a yes answer to any of these questions, then you'd proceed to look at the other six questions that really make up the CRAFT. Really a series of 6 questions that you could ask, and the CRAFT is an acronym for C-R-A-F-F-T. C is the first question. That's asking if the youth has ever been in a car that was driven by someone who was high or using drugs, including themselves, whether they've ever used drugs or alcohol to relax or feel better, whether they've ever used alcohol or drugs while alone, whether they've ever forgotten things while using drugs or alcohol, whether they've ever been encouraged by family or friends to cut down or stop using drugs or drinking, or whether they've ever gotten in trouble while using alcohol or drugs. So a yes answer to one of these questions should trigger some sort of conversation around prevention and around drug use. A yes answer on 2 of these really indicates that there might be a need for further assessment for a substance abuse problem. And a yes answer on 3 of these really indicates that the youth has a high probability of having a substance use disorder on axis 1. The MIR program is really an inpatient level of care, and it meets the criteria for 2 ASAM levels of care. ASAM is the American Society for Addiction Medicine, and basically MIR meets level 3.7 and 3.5 levels of inpatient care. 3.7 really is a level of care that requires detoxification for severe withdrawals, moderate to severe withdrawal symptoms. 3.5 would be kids that don't need medication for withdrawal or detoxification services. Basically, kids that need a referral to MIR are kids who are at risk for immediate relapse, kids whose use presents great risk to them, both in terms of the actual use of the substance and the behaviors that go along with the substance. Kids would have disruption in multiple life domains. They'd be having trouble in school, trouble with family or friends, might be court involved due to their drug use. Essentially, kids need MIR when they need to be in a 24-hour level of supervised care so that they don't immediately relapse. Also, kids would need MIR if there are not supports in place in the community for them to sort of maintain any kind of relapse-free functioning. This slide basically is a little bit misleading. The first line says that MIR program is voluntary. Well, you know, I think it's a program for adolescents, and it, in fact, for the most part is voluntary, but most of the time, the first time that kids come to MIR, it's not their idea. It's someone else's idea. So kids need to be willing to come to MIR for treatment. We can't accept kids on a Section 12, which would be kids that have mental health issues that are to the extent that they're at risk to themselves or others. But we do routinely accept kids to MIR on a Section 35. And a Section 35 is court-mandated treatment for any individual whose substance use puts them at risk for themselves or for others. So we do routinely get kids that are court-ordered on Section 35s. The MIR program is paid for through third-party reimbursement through insurance payment. That most of the kids that are referred to MIR need to go to a designated emergency screening team or an emergency department to be screened for prior authorization for the program. An exception to this would be any kid who has MBHP. You can make a direct call to the program, and nursing staff can start an intake and can obtain an authorization for treatment, and you can be directly admitted. If you have any questions about admissions or about whether a youth that you're working with is appropriate for this level of care, or what needs to happen to get authorization for this level of care, you can call the 508-860-1244 number, and nursing staff can help walk you through the process. We get our referrals basically from everywhere. Many of our referrals come through the courts. We often get referrals through schools and state agencies and primary care providers. And again, kids that do not have MBHP usually almost always need to be screened by an emergency service provider to get authorization for care because it's a high intensity level of care. We admit probably about 400 kids a year, so we have quite a few, we serve quite a few kids. The average length of stay is about 13 and a half days. We do have kids that stay with us longer, and that's often because they're involved with DCF, and there's difficulties around finding post-discharge living situation that is conducive to their recovery. Just in terms of the demographics, you know, the kids, who are the kids that use MIR? Almost 2/3 of the kids are male, a third female. 85% are 13 to 17, 14 or so percent are 18. Average age for a boy is around 16. Average age for a girl is closer to 17. So the girls that come to MIR are a little bit older. You've heard a lot about the different substances that are out there, different drugs that are out there, and you know these are kind of the categories and the substances that we see that our kids use. You know, as I was looking at these slides, I realized there's one major substance that I have not included in any of my slides, and I think it needs to be included, and that is tobacco and nicotine. That 80% of our kids come to MIR are addicted to nicotine along with using these other substances. The sort of trend that you heard about earlier about opiates is certainly a trend that we've seen since we've opened in 2007. We see a lot of kids who started off by using prescription pain medicine that they got from their parents' or their grandparents' medicine cabinet or from their friend's medicine cabinet. And we see these kids progressing to the use of heroin. And basically that happens for two reasons. One is that prescription medicine often is harder and harder to get out on the streets. And two, heroin is cheap and available. And just an example would be you can get a bag of heroin for the same price as a pack of cigarettes. So you can get a bag of heroin for $7. We serve kids from Boston through Beckett, and kids in any high school in this state can find out where to obtain heroin. If we look at the primary drugs that kids use when they come to us, certainly it looks at marijuana as a primary drug that many of our kids use. Most of our kids are polysubstance abusers. Most of our kids are not purists. They use many different substances. If you look at the heroin numbers and the opiate numbers, if you add those together, as a primary drug of choice, you've got over a quarter of our kids that are using opiates when they come to us. I think a particularly striking statistic here is the last one, and that is over 15% of our kids that are admitted to either the MIR program or the CASTLE program have used IV drugs within the last week. And I think that's just remarkable. Again, this is just another slide that has to do with what drugs have been used in the last 30 days. And so even though some of these drugs might not be their primary drug of choice, you can see that there's heavy usage of very powerful drugs on a fairly recent basis. Marijuana continues to be the highest used drug of kids that come to us, but certainly many of the kids that we see are dependent on opiates. So what happens to a kid when they come to MIR? The MIR program is, again, an inpatient level of care, 24-hour-a-day treatment. We provide multidisciplinary treatment. We also provide integrated care, that the kids that we serve at MIR, up to 80% of them have a co-occurring mental health disorder. So we see very few kids that just are purely substance abusing. We have a clinical staff that includes a board-certified child psychiatry. Every kid that goes through the MIR program gets a comprehensive assessment that includes a psychiatric evaluation. It includes a psychosocial evaluation, and it includes a nursing and medical evaluation. The Milieu Environment is really very structured. Each kid will participate, or each kid will have 6 groups per day. So every day of the week there's 6 groups. These groups range from skill building groups to psychoeducational groups to clinical groups. Again, we provide medical monitoring on the unit. We have 24-hour nursing care. We have 2 nurses on 24 hours per day. Each youth that is admitted to MIR participates in individual, group, and family treatment. We try to have at least 2 family sessions while kids are on the unit, and that doesn't seem like a lot, but we serve kids from Pittsfield to Provincetown, and sometimes it's very difficult to make the family care accessible. We also provide some family psychoeducation groups at MIR, and we spend a lot of time providing aftercare coordination and making sure that there's a comprehensive plan for each youth that's discharged back into the community. Again, 24-hour medical care. This is particularly important for kids that are on a detox protocol. MIR, first and foremost, the MIR is a safe environment that We use a motivational interviewing approach to working with our kids at MIR, and we believe in kind of a model that has to do with kind of stages of change, which is a Transtheoretical Model. And our belief around how do people change, it's really, and this has a lot to do with a motivational interviewing. Motivational interviewing is very client-centered, and it has a lot to do with empathy and reflexive listening. We find this approach to work very well with adolescents because it really respects their autonomy and it really respects their choice in what happens to them on MIR. We look at motivation as a stage or a state that's not fixed. Our belief is that really the most powerful change occurs, and the change that's most long-lived is change that's intrinsically motivated rather than extrinsically motivated. And motivational interviewing really is about how to intrinsically motivate the youth to make changes in their drug use. What we really try to do is help kids become interested in changing. That we're really not about confronting kids around changing or trying to force them to change. What we try to do is help kids develop a discrepancy between what they want in their lives and their goals and their values and their present drug use. And eventually, hopefully, kids are able to see that there's a discrepancy between what they want in their lives and their use of their drugs. Once kids are able to buy into the fact or become interested or concerned about making a change or feel that they need to change, we help them organize a plan of action around how to change. We also work around trying to help promote some skills that they have neglected or have not developed so that they're able to maintain a change. Again, the principles of motivational interviewing, it's really expressing empathy and reflective listening, that we reflect back a kid's reality, basically. That we are not about confronting kids around their views about whether they have a problem or not. We accept the fact when kids tell us that they get some benefits or some positive things from drugs, we sort of accept their version. We listen to what they say about their use. We avoid really direct argumentation and direct confrontation. Everything we do is about helping the kid move towards change and move away from resistance. And we found that the more that we confront and the more that we disagree and the less client-centered that we are, the more likely we are to increase their resistance. So we listen to the kid's story and we listen to their view of things. Eventually, what we try to do is help promote a feeling in the kids that they have some control over changes in their lives and they have power over that change. We really follow a Transtheoretical Model here. This was developed by Prochaska and DiClemente. And basically, it talks about motivation and change in terms of stages rather than in terms of a straight line. And the belief is that individuals who are making changes really go back and forth between different stages. Example would be, you might meet with a kid who's just been admitted to MIR, and you might, and that kid would be on a unit where their freedoms are pretty much curtailed. They're not in their neighborhood. Their existence is pretty scheduled, so they know they're at a significant level of care. And you can ask them, do you think that you have a substance abuse problem? And many times, the youth will say to you, I don't think I have a substance use problem. My mother thinks I have a problem, or my probation officer thinks I have a problem, or I was caught with marijuana in school, and my school thinks I have a problem, but I don't think I have a problem. We take that as an opportunity to kind of explore with the youth. We see that youth as being in a pre-contemplative stage of change. In the old days, the way that we would look at that kind of situation is we would say, this person is in denial, and it's important for us to confront that denial so that they can realize that they have a problem. Using a motivational interviewing approach and being sensitive to the stages of change, what we try to do with kids that are at this point in the stage of change, in a pre-contemplative stage, is to elicit from them both the cost and the benefits of their drug use, and elicit the cost and the benefits of changing their use. So we get them to basically get involved in making a decisional balance of change versus staying the same. And that through ongoing conversation and ongoing exploration, kids move to a point where the balance tips away from staying the same and continuing with the same usage to making a change in their usage. And once kids are able to see that shift in the balance, then they start to contemplate the fact that they might need to change their behavior. Once they reach a contemplative stage, then we're able to talk with them about making a commitment to change and make some plans around what specific things need to happen to change. So, basically, by following the stages of change model, we're able to tailor our intervention with each youth based on where they are. We believe that one of the major focuses of care on MIR is to move kids along in terms of their readiness to change. Basically, you know, the four goals for a kid being admitted to the MIR program is first and foremost to stabilize them physically, psychologically, 2, to provide a comprehensive assessment, 3, to engage the youth and family in a recovery process, and 4, to provide a comprehensive discharge plan where adequate community supports exist when the youth is discharged. So a major part of what we're trying to do is help kids move along in terms of readiness. One of the tools that we use to determine whether that in fact is taking place is called the Socrates. You have a Socrates in your packet. Socrates is more or less a personal drug inventory, 19-item measure that's in the public domain. You don't need any special training to score it. Basically, there are 3 subscales in the Socrates which we look at to determine whether a youth has kind of moved in terms of their readiness while they have been on the MIR unit. We give the Socrates at admission, and we give the Socrates at discharge. And these 3 scales represent the D scale scores, represents a subscale that's called problem recognition. The E scores represents a subscale that's around ambivalence to change. And the F scores represents a subscale that coincides with taking action. So we use the Socrates, and we particularly look at the D scores and the F scores to see whether there's been significant improvement or significant change on those 2 subscales to indicate whether kids are more ready to make change, more motivated at discharge than when they were admitted. This slide really is an analysis of the Socrates scores for kids that were discharged between January and July of last year. And basically it shows that there is significant change both on the problem recognition scale and the taking action scale. So we take this as evidence that, you know, kids are moving in a positive direction in terms of readiness to change. And again, this is something that's in your packet. I don't know what kind of capacity you work with kids on, but it is something that can be used as a way to check in on their actual readiness. One of the things that we spend the most time on on the MIR unit is making sure that there is an adequate continuing care plan for every youth that's discharged from the MIR program. Close to 30% of our kids that are discharged from MIR are admitted to an adolescent residential program at discharge. And these adolescent programs are funded by the Bureau of Substance Abuse Services. There are 5 of them in the state, 4 of which are gender specific. These are programs that serve kids between the ages of 13 and 17. Most of the programs, 4 of the programs are 15-bed programs. We have one in Worcester, which is the Highland Grace House program, which CHL also runs, and that's a program for females, adolescent girls who are trying to recover from substance abuse. On average, they're there 90 days. Services are paid for by the Bureau of Substance Abuse Services with some co-payment based on the ability to pay of the family. So this is one discharge plan for 30% of our kids. The rest of our kids, and that doesn't mean that just 30% of our kids need residential care when they leave us. It means that 30% of them are willing to voluntarily go to a 90-day program. The rest of our kids are referred to whatever we can do along the lines of a comprehensive community care plan. In Worcester, that plan would include intensive outpatient treatment, which you'll hear about a little later. We also often refer kids to the CLEAR program at Luck, which is an intensive community-based program that has a lot to do with intensive case management and education. We refer kids to self-help groups that exist in the community. We really need to know and do know the support services that are available for kids throughout the state. One major support that we refer kids to is a recovery high school. And I think this is a significant thing to talk about today because this is something that's coming to your area soon, we hope. Basically, at the present time, there are 4 recovery high schools in the state, one in Boston, one in North Shore, one in the Southeast in Brockton, one in Springfield. And basically, these are small high schools, I think between 30 and 50 kids in each setting, that are really designed around promoting recovery and promoting relapse-free functioning. Many of our kids, if we refer them back to their home school, their home high school, will not really survive because the social norm in your typical high school often is not around sobriety or recovery, but is around use. So these recovery high schools that have been developed have a great deal of clinical supports and a lot of sophistication on how to help kids maintain a recovery and a relapse-free functioning when they're out in the community. There's just a request for proposals that has gone out in the last couple of months, and Worcester has been identified as the next area to get recovery high school. And if all goes well, hopefully I think it will, as of August, there will be a new recovery high school in Worcester that will be accepting kids. So this is big news. We've been lobbying for this for a long time. And in terms of supports in the community, this is a major one that Worcester has. Our admissions line is open 24 hours a day, 7 days a week. If you have any questions about a kid that you're concerned about that might need this level of care, if you call the 508-860-1244 or 508-438-5642 line, you can speak directly with our nursing staff and they can tell you whether MIR is the appropriate level of care for the youth that you're concerned about, or they can point you to where a more appropriate level of care might be, and 2, they can help walk you through the admissions process and the process for getting authorization.